It's really important not to just throw a medication at the patient. It's important to understand what specific factors are contributing to their elevated blood pressures. A lot of people have primary hypertension. Some percentage of the population has secondary causes of hypertension, and those are under-tested for and underdiagnosed. If you don't address those things, throwing medications is not going to result in a positive outcome. We have to understand that getting diagnosed early on with the right kind of diagnosis, making sure that you have the right workup done, the right lab work done, and understanding that there are more options these days than there were 5 years ago, including things like renal denervation, is really, really important.
High blood pressure affects nearly half of adults, and yet most people either don't know they have it, don't understand what the numbers mean, or don't realize how serious the long-term consequences can really be. Recently, new hypertension guidelines and treatment options, including new medications and procedures like renal artery denervation, have changed how cardiologists think about managing blood pressure. But what does that actually mean for patients? So, welcome back to Cardiovascular Therapeutics Unplugged, real conversations about heart treatments that change lives. Dr. Mehra, today we're breaking down what's new, what matters, and what patients need to understand about managing high blood pressure. It's nice to see you again. I'm glad we're having this conversation. How are you doing today?
I'm doing great. Once again, thank you for hosting this episode. I'm looking forward to talking about hypertension, and once again, the views on this podcast are entirely mine. I might mention certain drugs, certain institutions, but these views are my personal views. And if you have any specific situation, clinical situation, please discuss it with your own doctor regarding that.
Absolutely. And today we're talking about high blood pressure, which I spoke to a little bit earlier, is super common. So, being that high blood pressure is so common, it's almost like a lot of people tend to dismiss it. But from your perspective, why is hypertension still one of the most dangerous and underestimated conditions in cardiovascular care?
So let's dive deep into hypertension today. Hypertension is one of the most common things that we encounter in practice, and there's constant changes in guidelines, and more recently, there was an update to the hypertension treatment guidelines. So that's why I wanted to discuss this topic and just kind of educate the masses about it. So high blood pressure, let's start with just talking in general about hypertension. Hypertension is the most prevalent and modifiable risk factor for development of cardiovascular disease. Why is hypertension important? It is important because we know it's the silent killer. It affects you, increases your risk of coronary artery disease, it increases your risk of end organ damage such as kidney failure, stroke, it increases the risk of having dementia, it increases the risk of having heart failure. That's why cardiologists are so paranoid about controlling blood pressure in their patients. So more recently, amongst the adults in the United States, the prevalence of hypertension is about 46%, with prevalence varying by age or gender. But as the aging population increases, blood pressures have continued to rise. And there's more and more emphasis on awareness and treatment and control of hypertension because it is underdiagnosed and it is undertreated. So that's why it's important to recognize it early and understand why it is important to control it. And if you look at the most recent guidelines update by the American College of Cardiology, there's in men and women, the total risk of cardiovascular disease continues to increase with every 5 to 10 millimeters of mercury rise in blood pressure. And that's a graded increase in your risk of a cardiovascular event over the course of 10 to 20 years. So it's very, very important that the patients as well as their physicians understand the urgency that is there to control blood pressure adequately and treat it with all the tools that we have at our disposal.
Absolutely. And as you mentioned, that there have been some updates to hypertension guidelines recently. In simple terms, can you kind of explain what actually changed and why does it matter for everyday patients?
Yeah, so I'm just going to go briefly through what, we had. The last guideline update was in 2017, and now 8 years later in 2025, we had another guideline update. Some of the things were some terminology that was changed, such as what's called hypertensive urgency is now qualified as severe hypertension. But other things that were recognized are, uh, you want to recognize secondary causes of hypertension that are underdiagnosed in the population, such as primary aldosteronism. That is, a lot of people have primary hypertension, but some percentage of the population has secondary causes of hypertension, and those are undertested for and underdiagnosed, and therefore not treated adequately. So, one of the things was guideline update, which said that screening for primary aldosteronism is recommended so that you can recognize, the right patient population and the drugs that they need for treatment. The other thing is there was an emphasis on lifestyle and psychosocial approaches to treatment of hypertension. It's important to recognize that patients are not decreasing the amount of salt intake, for instance, in their diet. It was not emphasized as much in the last set of guidelines. The thresholds for treatment also changed slightly, and our guidelines now suggest treating patients if their blood pressures are running essentially over 130 over 80. So those guideline updates are new. They were somewhat present in the last one, but there's more emphasis on treating early on in the new guidelines. One of the other things that was there is treating diabetes, understanding chronic kidney disease, some new guideline updates, and early recognition of patients with chronic kidney disease. Some guideline changes in the treatment of patients who have hemorrhagic strokes, and then recognition of vascular dementia, as well as some treatment guideline changes in resistant hypertension. So that's where our talk is going to lead us into resistant hypertension, and when I talk about renal denervation.
Absolutely. And I think that a lot of patients, they'll hear numbers like, for example, 120 over 80 or 130 over 90, but what do those thresholds really mean? And at what point should someone be concerned about those numbers?
Yeah. So, like I said, it's throughout the years with different guideline updates, we've always changed the stages of hypertension, but now they've put out another set of kind of categories where hypertension is now categorized as either normal, or it's elevated, or it's stage 1 or stage 2. Those are the 4 stages of hypertension now. And if your systolic blood pressure, the top number is less than 120 and the bottom number is less than 80, then you're in the normal range. So less than 120 over 80 essentially is normal. If you're in the 120 to 129 and less than 80, then you're in the elevated category. And then hypertension is qualified as stage 1 or stage 2. If it's over 130 or over 80, systolic over 130 or diastolic over 80, then you're in the stage 1. In stage 2, if you're over 140 or over 90 and diastolic, then you're stage 2. So so understanding that is basically the categories that we have to use now. For using these categories, one of the most important things to understand is that we have to accurately measure blood pressure. And that is done in two ways. We emphasize measuring blood pressure in the office as well as home blood pressure monitoring, so that some people who might have things like white coat hypertension are not misdiagnosed with having elevated blood pressures. So that is an important thing to consider. And there's a standardized way that we recommend that patients' blood pressure is measured. A few of the things that we stress upon is that when they come into the office, that they haven't had caffeine, they haven't exercised right before coming in, they haven't smoked for at least 30 minutes before measurement. They've emptied their bladder. If they're holding on if they're coming in with a full bladder, they might have elevated blood pressures. Using the right kind of a validated blood pressure cuff, using the right size blood pressure cuff. Sometimes blood pressure cuffs are too small or too big for certain people. You want to keep your arm at supported at the level of the heart. That's important. The patient should be relaxed for a few minutes and sitting in a chair with their legs uncrossed for at least 5 minutes before you measure their blood pressure. And they should not be talking, so that your talking does not affect your blood pressure reading while the blood pressure is being measured. It shouldn't be too cold or too hot in the room. And then usually we recommend taking 2 blood pressure readings. So these are the basics that we follow in our cardiology clinic, so that we don't get aberrant blood pressure readings.
And so, what are some of the causes of hypertension?
Yeah, so to understand how you want to treat these patients, and we have to first understand what is the cause of hypertension in our patient. And hypertension is a complex problem, which is an interplay of behavioral factors, environmental factors, genetic factors, hormonal factors, dietary factors. So it's really important to understand what exactly is causing the patient's elevated blood pressures. So most commonly what we see is, for example, somebody's got elevated salt intake. They've got low potassium intake. Those things can lead to hypertension. Somebody's smoking cigarettes, or they have alcohol overuse. That can lead to elevated blood pressures. They might have recent weight gain or insulin resistance or diabetes. They might have underlying things like obstructive sleep apnea that is causing them to have elevated blood pressures due to and not getting a good amount of rest at night. They might have psychosocial stressors that are causing them to have elevated blood pressure. So it's really important not to just throw a medication at the patient. It's important to understand what specific factors are contributing to their elevated blood pressures. So once we have an understanding of a good history from the patient, you order some basic tests to see what's going on with the patient. Some of the tests that we order are a complete blood cell count, electrolytes such as serum potassium and sodium, serum creatinine level, which is blood creatinine level is a marker of your kidney function, your lipid profile, your fasting blood glucose, your urinalysis, an EKG, thyroid profile, excuse me. Those are the things that help us decide what's going on with the patient physiologically. So understanding genetic causes is important as well. There's blood pressure. The more studies we do, the more we realize that there's a heritable component to this, and there's hundreds of genetic kind of locus that are capable of affecting blood pressures, and that's going to come into play as we target blood pressure genetically in the future. So it's really important that we get to the root cause of the problem and then treat it appropriately. Understanding these basic complex interplay of things that contribute to hypertension is important. But once we've looked at a patient, there's certain secondary causes that you also have to look into. So, like I said, somebody could have obstructive sleep apnea. It's really important that you carry out testing in addition to the basic blood tests that I talked about, that you screen them for sleep apnea. So a sleep study is a must in a lot of these patients. Primary aldosteronism. This is becoming more and more focused on. The prevalence is about 5 to 25% in the population with hypertension, and it's been underdiagnosed. So there's more emphasis in the 2025 guidelines to, look at the serum values of potassium, sodium, aldosterone, and see if somebody has primary aldosteronism. The way it shows up is generally a patient presents with low potassium levels with hypertension. They might have muscle cramps. They might have weakness. Sometimes they have an incidentally discovered adrenal mass. So when you're not able to figure out what's going on, sometimes it's really important to screen them for this. Drug and alcohol interplay has to be looked at. Urine drug screen, a history asking about alcohol use is very, very important. One of the other things to consider is what's called renovascular hypertension, making sure that they don't have blockages in the arteries of their kidneys, which is leading to secondary hypertension. This is a very important cause of resistant hypertension. So an ultrasound of the arteries of the kidneys is the most common way to figure this out. Also look for thyroid issues, looking for what's called a pheochromocytoma with a CAT scan of the abdomen pelvis is important to rule out resistant hypertension. In some younger adults, looking for aortic coarctation is important. Things like Cushing's syndrome, which is quite rare, it's less than 0.1% of the population, is also an important thing to look at when screening for secondary hypertension. So once you've done your workup to look for these causes, then you can get into what you need to do to treat these patients. So the next step is, I think you were asking me about the medications and what are the new medications and approaches that a patient should know about, correct?
Yeah, absolutely.
So to understand medications, again, we have to know what are we trying to achieve. We're trying to lower the blood pressure when the average blood pressure is greater than 140 millimeters of mercury. And why are we doing this? Once again, we're lowering the blood pressure because every 5 to 6 millimeters of mercury lowered decreases your risk of a cardiovascular event. So in adults, initiation of blood pressure medications is carried out when the average systolic blood pressure is greater than 140 or your diastolic blood pressure is greater than 90. So that's where treatment comes in. And we've had several drugs that we've used over the course of the years to treat hypertension. And the most common drugs are the different classes of drugs that we use. The most common ones are you might have heard of hydrochlorothiazide or chlorthalidone. Those are thiazide type diuretics that are initiated. ACE inhibitors and ARBs are also some of the common drugs. Calcium channel blockers, diuretics, potassium sparing diuretics, beta blockers. These are some of the most common drugs that are used. In addition, alpha blockers have been used, direct vasodilators are used. More recently, there was the new class of drug has been approved to treat hypertension, which is called an endothelin receptor antagonist, which is indicated as an add-on therapy when blood pressure is not adequately controlled. So Those are essentially the classes of drugs.
And speaking about medications, some patients are on multiple medications and still struggle to really control their blood pressure. So at what point do you step back and say, maybe there's a different strategy we should take?
Yeah, so, again, most patients are controlled on at least 2 to 3 medications. So you have to escalate their doses of medications appropriately based on the guidelines again. But it is really important, again, to look at that complex interplay of different things like genetics and life choices and chronic stress and um, possibly bad habits like smoking and excessive drinking. If you don't address those things, throwing medications is not going to result in a positive outcome. So it's really important that all of the therapies recommended for hypertension are used in conjunction with lifestyle changes and dietary changes. One of the most important diets that we've had over the years is called the DASH diet, the dietary approaches to stop hypertension. The DASH diet is essentially a low sodium diet with potassium supplementation that has shown benefit in reducing hypertension. Combining that with moderate exercise, which is defined as greater than 150 minutes of resistance exercise 2 to 3 times a week, results in lower blood pressures. So, you have to implement those things in addition to your blood pressure medications. Again, treating things like obstructive sleep apnea is very, very important. Now, once you don't achieve your goal and somebody is on 3 or more medications and you have gone through your algorithm of secondary hypertension, you've ruled out things like primary aldosteronism, of pheochromocytomas, and renal artery stenosis. One of the things to consider is renal artery denervation, which we mentioned right in the beginning. This is a new kind of therapy that has come into play more recently. We've had this technology around for over 10 years, but the initial trials, the Simplicity hypertension trials, did not show a significant benefit about 10 years ago. So there's been a resurgence of interest in it, in this technology after the more recent studies have shown benefit. So when do we start thinking about renal artery denervation? Once you find somebody's got resistant hypertension, which is defined as blood pressure above goal despite treatment with 3 antihypertensive medications, then we start thinking that somebody might have resistant hypertension. And that's when you start considering renal artery denervation. What is renal artery denervation? Renal artery denervation is basically your kidney arteries are surrounded by these nerves, just simply speaking, that control your blood pressure. And if we can denervate, meaning decrease the amount of sympathetic activation that these nerves are providing to contribute to hypertension, we can possibly decrease blood pressure. The sympathetic nervous system is an important contributor to hypertension, partly through the renal sympathetic nerve activity. So we've got antihypertensive medications that work by blocking the sympathetic nervous system. And renal artery denervation is a therapeutic alternative which does the same thing as an adjunct to other pharmacologic therapy to achieve this effect. So what we're trying to do is kind of blunt the output from the renal nerves to control blood pressure. And that's why this is just a great technology. It's a minimally invasive way of going up to the renal arteries with catheters and then using these catheters to ablate these nerves from within the renal arteries, the kidney arteries. It's a great way of treating resistant hypertension. So multiple trials were carried out. We first had trials in 2014, like I said, simplicity hypertension studies, which didn't really show significant amount of benefit. But more recently, the spiral hypertension trials and the radiance trials showed benefit. We've got 3 approved devices, which are on the market: the Medtronic spiral system, the Recor Paradise system, and then there's another ablative solution system which uses alcohol for ablation. But most commonly, what we're using in our hospitals locally is the Medtronic spiral system, and I have been using this in my resistant hypertension patients, and I've had significant amount of success in it at our local hospitals.
And whenever a new procedure enters the conversation, patients worry, is this experimental? Is this risky? So how do you evaluate whether something like renal denervation is appropriate?
Yeah, so everything has its risks and benefit. Again, once you're treating the patient appropriately with the right kind of drugs, you've made lifestyle changes, you've diagnosed, you've ruled out other causes of secondary hypertension. This is an effective way of blunting their sympathetic response. I make the patients aware of the risks. I make the patients aware of the benefits and the possible adverse events that can happen. It's a catheter-based procedure, just like a cardiac catheterization, where you go up through the groin. So there's a risk of bleeding, hematomas. We give a little contrast dye, so that has its own risk. But all these risks of serious complications, serious adverse events, less than 1%. So the benefit of controlling, again, it's everything in medicine is a risk-benefit ratio. So the benefit of controlling hypertension and not having downstream effects of end organ damage, in my opinion, outweigh the possible adverse events that can happen with this therapy. Most patients will experience a modest kind of sustained reduction in blood pressure, and so we don't have long-term data, but like I said, the spiral hypertension on med study, which enrolled patients, about over 300 patients in multiple clinical centers, over 50 clinical centers, showed that there was sustained significant benefit in these patients when they were treated with renal denervation.
And if there is someone listening right now that does have high blood pressure or has struggled to control it, what is the most important thing that they should do differently starting tomorrow?
Seeing your physician early on, understanding that blood pressure is not a benign thing. It has serious side effects, serious long-term effects, serious short-term effects. Controlling it is paramount. We have to understand that getting diagnosed early on with the right kind of diagnosis, making sure that you get on the right medications, making sure that you have the right workup done, the right lab work done, and understanding that there are more options these days than there were 5 years ago, including things like renal denervation, is really, really important. Lifestyle changes, I think, are more important than anything else. Simple things like diagnosing sleep apnea and treating it, makes a huge difference in treating hypertension. And again, this is the silent killer. It leads to an increased risk of stroke, increased risk of heart disease, increased risk of dementia, increased risk of kidney failure. So ignoring it is not the wisest thing to do.
Absolutely. And high blood pressure may be common, but the decisions around treating it are not simple. So understanding your numbers, your options, and when to escalate care can really make the difference between long-term risk and long-term protection. So Dr. Mehra, thank you for breaking down what's new and what truly matters. This is Cardiovascular Therapeutics Unplugged, real conversations about heart treatments that change lives. Thank you so much for this information, Dr. Mehra, and I can't wait to speak to you again soon.